771 in Medic 6. You're seeing a 74-year-old male, shortness of breath.
Chest trauma is a significant cause of injury and death. 70 to 80% of blunt chest traumas are caused by motor vehicle accidents. Other causes include falls, sports injuries, acts of violence, crush, and blast injuries. The mechanism of injury is an important consideration in the assessment and treatment of all chest trauma. In comparison to other trauma-type injuries, chest injuries are not usually dramatic in appearance. But don't let this fool you.
Will you get some alfalfa pellets for a laddie?
Yeah, how many scoops?
I don't know.
4?
Yeah.
All right.
Blunt trauma to the chest can have serious and often fatal consequences.
Hey! Whoa! James! James! What happened? James!
A thorough understanding of the anatomy and physiology of the thoracic cavity will help you better assess and identify life-threatening injuries. Blunt chest trauma accounts for 1/4 of all trauma deaths.
Main challenges and concerns in treating patients with traumatic chest injuries are very basic if you just think about what's in there. I mean, everything that is central and important to the function of life is within the chest cavity. The lungs, the great vessels, the heart. So anytime you have a traumatic chest injury, your concerns are that any of those vital sources of life in the human being have been damaged to the point of catastrophe. So your assessments and your managements are going to be based on taking care of those very basic parts of being alive.
The thoracic cavity is the area between the base of the neck and the diaphragm and is basically surrounded by the rib cage. Inside are the major organs of the respiratory and circulatory system, the heart, lungs, and major blood vessels. The mediastinum is the middle section of the thoracic cavity between the lungs and behind the sternum. With the exception of the lungs, this area contains the major organs of the chest, the heart, parts of the aorta, trachea, and esophagus. Depending on the mechanism of injury, blunt trauma can affect any one or all of the components of the chest wall and thoracic cavity, with devastating effects. Major injuries may involve disruptions to the flow of air, blood, or both. Inside the thoracic cavity are two types of membranes, the parietal pleura that lines the cavity wall and the visceral pleura, which covers the organs. The space between these two membranes is the pleural cavity or potential space. When trauma or infection occurs, fluid often fills this space. When the chest wall expands on inhalation, negative pressure or a vacuum between the two pleura increases, allowing the lungs to inflate and pull in air. If a puncture occurs to any or all of these membranes, the seal is broken and air is sucked into the thoracic cavity. This air creates pressure on the lung, causing the lung to collapse. This is called a pneumothorax. A pneumothorax can be caused even when there is no open wound to the chest. Trapped air can expand and create enough pressure to collapse both lungs, compressing the large vessels and the heart. This is a tension pneumothorax. Chest wall injuries, such as rib fractures, are common. These injuries are painful and make breathing difficult, compromising ventilation. A rare but potentially life-threatening injury. It occurs when two or more adjacent ribs are broken in several places and is no longer attached to the rib cage. It collapses on inspiration and bulges on expiration, causing intrathoracic pressure changes and severe respiratory distress. It is important to stabilize these injuries to prevent further damage or pain.
We should consider people with chest injuries fragile as well, because if we have major blood vessels that are torn or leaking, if we have a blunt trauma, for instance, where there's been tremendous tearing kind of forces, a picture, if you will, you've got the aorta coming up out of the heart in a big loop, and it's held in place by a ligament at the top of it. So if that aorta is flying forward at 60 miles per hour and a ligament pulls back, holding it to the spine, you can get a tear or a small leak there. And when you get injuries like that to big vessels, to lung tissue, The concern should be that could I make the pain worse, or could I make the injury worse by bouncing this person around or squeezing them too hard? And I think certainly when we look at patients who have injuries, whether it be skeletal, vascular, organ injuries, that we should be thinking about that they may be in a partial tear, or they may be in a situation that could be worsened if we're not careful.
There are two general categories of chest injuries, open and closed. Closed injuries are a result of blunt trauma, like MBAs, falls, or blows to the chest. Open injuries are usually a result of something penetrating the chest, like a bullet, a knife, or other objects. The signs and symptoms of chest injuries will vary widely depending on the mechanism of injury and the organ systems that are injured.
All right, let me see where you got kicked. What'd you get kicked by? A horse, okay. All right, Billy's got a large contusion right here. You can feel the crepitus. I'm just gonna check you out real quick. Do you hurt anywhere else?
Certainly, if you've got a patient that's got chest trauma, whether it's blunt or penetrating, and they look bad and they're not responsive, bingo, this patient's in bad trouble. If you've got a patient that's responsive to you and they're breathing, but they seem to have increasing distress, you watch for things like weakening peripheral pulses, which gives you some sense that something's happening centrally that's not allowing decent cardiac output to the outside. If you start to see the blood pressure with an odd change where the systolic's dropping but the diastolic's rising, it makes you think about pressures within the chest, either bleeding around the heart or within the mediastinum that's compressing the heart and the great vessels and affecting their ability to circulate. These types of things are going to be significant.
Okay, his oxygen saturation is only at 8%, so we need to get him on some oxygen by mask, 15 liters.
Lung sounds are diminished on his right side.
Okay.
Let's get O2.
When you listen to the lungs, do you have diminished sounds on one side or the other? It tells you the injury of the lung is impairing the capacity of that lung to inflate. If that worsens, after your initial assessment, this patient is progressing to the loss of that lung and maybe even a tension pneumothorax, which means not only is that lung gone, but now the great vessels are compressed and the other lung is in jeopardy. These are the kinds of things that we use things like chest tubes and needle decompressions for to try to relieve that pressure.
Does it hurt a lot when you breathe? Okay, what we're gonna need to do is put a needle in your chest, make it easier for you to breathe, okay? You're getting pressure in your chest, okay? That's why it's so hard to breathe.
Signs of significant thoracic injury may be subtle or even absent. Your patient may not even complain initially about any injury to the chest. Have a high index of suspicion based on the MOI. Do a thorough examination and begin your treatment.
Your primary concerns in making an assessment on a chest trauma patient is to get down to those basic things, airway, breathing, circulation. And I know that sounds overly simple for such a complex organism, but basically what we're looking at is a possible insult to the respiratory system and the circulatory system. So beginning at the top, if the airway's open, what's the quality of breathing? Assessing the chest wall to see if its movements are together so that we can see that there's not a paradoxical motion, but the lungs seem to be inflating. To check to see the effort of breathing. Is the patient working hard to breathe, which would imply that there's also been an insult or an impairment of their ability to breathe effortlessly. And then finally, sense of how the circulation is doing. If the circulation is holding up peripherally, then within the chest, hopefully the damage hasn't been so catastrophic. But then again, a quick look at the patient to see what you can see and feel and how they're doing, whether or not they're responding to you, gives you some sense of how serious the injury is. Beyond that, because you have the insult to the chest, and because some of the injuries take time to develop, for instance, if they're bleeding into the chest cavity, it goes back to the old rule, 100% of the stuff fills 100% of the space. So if you're losing blood into the mediastinum, it's going to be, again, to compress the great vessels, which are going to impair the function of the heart, and it's also going to come into play as far as crowding out space that should be available for the lungs. So any sense that the patient gets worse calls for another return assessment.
After a scene safety determination and an assessment of the mechanism of injury, establish and maintain inline spinal stabilization if indicated. Gather as much history as possible about the patient and the event. Begin your initial assessment by forming a general impression of your patient. Are they cyanotic? Is there respiratory distress? Is the breathing shallow and rapid? If you identify life-threatening injuries, act fast. Rapid evacuation to a trauma center is necessary for life-saving interventions.
The most important thing for a BLS provider to remember when treating chest trauma victims is, again, to go back to the basic. Constant evaluation of the quality of the patient's respirations. Are they able to ventilate on their own? What is that respiratory rate like? Recent research in ventilations has showed us that if the ventilatory rate is far below or far above what we consider to be normal respiratory rates for patients, that their hypoxia increases. So we need to assist them if they're unable to maintain adequate, good rate, good ventilations, so that we can control that rate and control that exchange and assist that patient in maintaining good oxygenation.
Okay, before you put the collar on, let's take a look at his neck veins. Look a little distended. And trachea looks midline.
For a thorough assessment, you will need to cut the clothing from the patient's chest and inspect anteriorly, laterally, and in the axillary regions. Inspect the chest for DCAP BTLS, evidence of deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, or swelling. Treat any external bleeding, cover open wounds, and stabilize any flail segments. Also, look for lack of symmetry, or segments of the chest that might be moving in paradoxical or unusual motion. Signs and symptoms may include shortness of breath, chest pain, signs of respiratory distress, shock, bruising, or pain on palpation. Determine the patient's respiratory rate and depth. Assess for adequate and equal chest wall movement. Feel for chest wall tenderness or crepitus. Continuously monitor the patient for any deterioration in their respiratory condition.
Okay, James, we got a dressing on your chest now. We're going to put that needle in, all right? It's going to hurt a little bit, but we're going to help you breathe a lot easier. Is that oxygen helping you? Okay.
Determine if the patient is in severe respiratory distress based on visible dyspnea, retractions, cyanosis, or dramatically altered levels of consciousness. Check for breath sounds in the top and base of lungs. Determine if the sounds are present and equal. Absent or diminished breath sounds on one side may indicate a serious lung or chest injury or bronchial obstruction. If the breath sounds are absent or severely diminished on one side, quickly reassess the heart rate and quality. Suspect a tension pneumothorax if the heart rate is increasing, peripheral pulses are weak or absent, and the blood pressure is dropping.
The most important thing that we can do for people that are injured is to support circulation as best we can, but on the front end, again, management of that airway, management of that ventilatory rate, because they are hypoxic because of injury, and if we don't manage that, we're going to accelerate that. So monitoring the ability of the patient to breathe effectively, and continuing to get a handle on circulation and make sure that the patient isn't bleeding into the chest without us being aware of that compromise. All those things bring us back to making sure that we can protect circulation as much as possible, definitely provide adequate ventilation that protects them and prevents the hypoxia, and knowing that this patient that is continuing to show signs and symptoms that they might be decelerating or getting worse has to be at the trauma center that much more quickly so definitive care can be provided.
BLS providers should administer high-flow oxygen and closely monitor the airway at all times. Place the patient in a position of comfort, assist ventilations when necessary, and assist ALS. Treatments will be based on your findings. Chest injuries can be extremely painful. Pain management will be an important component of your care.
Pain management is kind of a new buzzword in the EMS industry, and the idea is that it's a very real concern, and our patients who are relaxed and have less pain may be better able to manage their own airway, be able to breathe a little better. The concern has always been that we're going to mask symptoms. So we ended up with a lot of medical directors that would limit the administration of pain medication so that they didn't mask the decisions, particularly like a belly patient, somebody's got belly trauma or belly problem. But I think more of us are looking at the medications that are available to us and the benefit to making the patient comfortable, particularly if they're conscious and still breathing, that we can make them more comfortable, make them in a better position to manage some of their own breathing and their airway, but to also doing so with caution and understanding the drugs. Morphine has been the standard in the industry. Protocols generally call for it to be administered.
Okay, James, I'm going to be poking on your chest here to find the spot. You need to go between your ribs. You're going to feel a big poke here in a second. You ready? Okay, all done. It's in there.
Depending on local protocols, some ALS providers can provide decompression of the pleural space by employing an immediate needle thoracotomy. Check with your medical director for guidelines. Providers should continue airway management, establish IV access, EKG monitoring, and transport immediately.
Putting you on a backboard and put you in on our cot and take you into the ambulance, okay? He's doing a lot better.
The advantage of ALS care in looking at patients who have received trauma to the chest is the ability to deliver patent airways. And because of the fact that we're doing advanced airway management, we may have other tools to help us to better monitor how well the patient is perfusing. So the first advantage, we have the opportunity to get a patent airway. We can get an intubation tube, or we can use a combi tube. We get something in place that protects the airway, makes it a solid airway so we have good exchange. Then on top of that, remembering to monitor our ventilatory rates and the quality of those respirations so we stay within that area that prevents hypoxia. The next piece is advanced life support will have tools like pulse oximetry and hopefully capnography, which are going to further enable us to make sure that we're doing everything we can to make sure that a patient who is already compromised and prone to hypoxia is not made worse by our inability to make sure they have the best chance by the best ventilations.
So we're putting some sticky pads on your chest and your arms for an EKG, okay?
The use of fluid therapy with chest injuries is evolving. Recommendations regarding fluid management are now based on the type of injury sustained. Check with your medical director for your protocols.
Over the last several years, there have been several studies that looked at our old rule of thumb, which said if you've got somebody that's severely hypovolemic and is surely bleeding either internally or externally, we gave them 2 large bore lines and hung 1,000 liters of lactated ringers and normal saline in each arm and just ran it in. I think recent research supports that, particularly with penetrating trauma victims, that could be a critical error. Basically, it's simple. If you have big holes in blood vessels, and I increase the pressure within those blood vessels by pushing in lots of IV fluid, that it's going to accelerate the rate of the bleed. So the idea is that we titrate our infusion of fluid to support the pressure within the vessels to enhance perfusion, but not running so much fluid in that we run the red cells out, because the oxygen carrying capacity of IV fluid is 0.
Okay, I need you to just breathe normally. Okay, try to hold real still. We're doing an EKG, okay?
Okay.
How you feeling?
Okay.
Okay.
Remember, regardless of the mechanism of injury, blunt chest trauma can result in serious consequences that require your immediate attention. Knowing how to quickly detect and treat these injuries is crucial.
Okay, your EKG looks pretty good. Okay? We're going to do now.
If someone were to ask me if there was some overriding take-home point that you should have about the tools of the trade that we use to manage patients, and chest trauma patients in particular that may need ventilatory airway support, people are always, what's the best device? You know, should I be using, is there a benefit to intubating versus using an LMA versus using a combi tube? The best device is the one that you are proficient in, and that device is made better by your ability to provide a backup if there's difficulty getting that in. End of the day, we need to have patent airways, we need to manage those airways correctly, and we need to keep an eye on ventilations. And if you walk away from that with any patient, you're in a pretty good place.